Good morning. Thank you very much for the very kind introduction. As was mentioned, the task that myself and my colleague James Chow have this morning is to discuss with you the treatment of the severely resorbed maxilla. Panos did a beautiful job discussing the FP1 and FP2 type of prosthesis, and we're going to go to FP3 and beyond and see how we can manage these cases graftlessly and with immediate loading. With that being said, we have to be able to look at the history of the zygoma implant in order to understand the proper application of it today. It is wonderful that zygoma implants are being used so much more today, but at the same time it's a little bit nerve-wracking because some of the principles and the dogmatic protocols that have made it so successful is being undermined. So to understand a zygoma implant, it's not an implant. An implant is placed in an alveolar bone. Of course, it's an implant, but it's an implant that also involves a maxillofacial anatomy as well as the paranasal sinuses. And management of the paranasal sinuses, the treatment of the potential issues that may arise with it is very critical. So whether it's the sphenoid, the frontal, the ethmoid, or the maxillary sinus itself, the clinician, the surgeon has to have a good understanding of how to deal with it. And then the implant is placed in the bone. It could be the maxilla proper, it could be a portion of the alveolus if it still remains, and definitely it is in the zygoma bone itself. So as you can see, it's just a little bit more complex than placing an implant in the alveolar bone itself. So let's take a quick journey from 1978, the original use of the zygoma implant, to its current application. The first paper that was published was in 1997. It was a German group that in 1978 placed regular implants in a resected patient, a maxillary resection case. The implants were placed in the zygoma bone, and then they were used as a retention component for a maxillary obturator. We did the same thing in Bauru, Brazil with PI Brannemark. We used 3.75 millimeter regular Brannemark implants. We placed it in the zygoma. And then custom abutments had to be made to come from the implant platform to the occlusal plane. Well, this made for potential complications with abutment screws fracturing and such. And the genius of Brannemark was to attach the abutment, if you will, to the implant, hence a very long, unusual implant, and the name zygoma implant. That was the origin of it, and basically this implant anchored distal bone that wasn't available. So, when we published the paper on protocols for placement of maxillofacial implants, one of the things that we talked about in the original paragraph was interdisciplinary management of these cases where the maxillofacial surgeon and the oncologic surgeon discuss whether the zygoma bone in a cancer patient can be saved or not. If it is not savable because it's infected with cancer, then when this bone is removed, the patient is not we cannot reconstruct them. And if the zygoma bone is saved, then we can actually go ahead and treat these patients with a fixed prosthesis. However, we have to recognize there is no maxillary alveolar support here, and this is a compromised case, and the clinician has to know that, and so does the patient. So what is not a compromised case? The ad modem Brannemark, which is the fixation of the implant platform at the maxillary alveolar bone, and also a bicortical fixation of the implant at the zygoma bone, the apex of the implant. Hence, a uniquely quad-cortically stabilized implant. Now, all the publications, the systematic reviews on the zygoma implant is based on that particular protocol. So, what are the contemporary objections to the original or the Brannemark protocol? The first one is the implant platform is too palatal. Well, if you look at the instruction manuals from day one all the way through 1990, 2000, and 2010, you can see that the implant platform is placed as close to the knife-edged ridge or the remaining alveolar bone. So the implant is not palatally placed. It's placed as close to the crestal bone as possible. The round drill, where you start the round drill, is what determines whether the implant will be in the right place or not. And as you can see on the picture to the right of the screen, that round burr position is incorrect. There's that crestal bone, that's where it should be, and if that's done, then the implant's placed in the proper position. So when you see this is the incorrect application of the Brannemark technique. This is not the Brannemark technique. It's the absolute incorrect application of it. So, the points we're going to review are there actually different techniques? There's a workshop later on today, and if there are different techniques, then there must be two different stations that teach you two different ways of doing it. So let's demystify this and see, is there actually two different techniques, or is there just one? And then we'll talk about clarifying the biomechanics. What is a technique? Any technique has a starting point, has an end point, and has a trajectory. That's basically what a technique is. So, in order to evaluate whether your patient is a zygoma candidate or not, we use the Panorex, and right away we try to figure out, are they patients for axial implants, tilted implants, zygoma implants, or quad zygoma? Once we have determined they're a zygoma case, then we proceed with three-dimensional radiography, where we'll use the Zaga classification, a radiographic evaluation classification that looks at the contour of the lateral maxillary wall as well as the degree of palatal resorption of the maxillary crest. And when you understand those two, then you understand what Zaga classification your patient is. A Zaga 0, or the Edmond Brandemark, has the implant platform at the crest, has the apex in the zygoma bone, and if the patient's lateral maxillary wall is convex, then the implant is inside the sinus. The implant is not inside the sinus because that's the technique. It is because the patient's lateral sinus wall is concave. But then if you take another patient who has slightly convex, the green contour of the lateral maxillary wall, the platform and the apex in the same place. You take a more convex, it's the same place. And you go to a Zaga 3 with very significant convexity of the lateral maxillary wall, the starting point and the end point of the implant is exactly in the same place. And also with a Zaga 4. So when you superimpose these patients together, it's all one technique because everything is in the exact same place. So when you look at this thing clinically, what you see is a Zaga 0, a Zaga 1, a Zaga 2, and a Zaga 3. They look different, not because the operator intentionally externalized the implant's mid-portion, it's because the implant's mid-portion was externalized because the patient's anatomy is different. One technique, 4 different patients. And then the last one, the maxillectomy patient or the severely resorbed patient, has absolutely no implant support at the platform. So when they talk about extrasinus technique in this article, it's not correct because this is the Zaga 3 Brandemark protocol. Another one here, it says Zaga 3 Brandemark protocol. Calling this an extrasinus technique only confuses the person who's trying to understand what's going on. The implant is engaged at the platform and engaged at the apex of the zygoma. A similar article, a Zaga 3 Brandemark technique. So this is not an extrasinus versus an intrasinus technique. This one actually is a modification, but it's not a very good modification. This is the intentional removal of the crestal bone in order to make the surgery easy. The surgery is easy for the practitioner, not good for the patient, because you're removing the support at the alveolar ridge. So, let's take a look at the second objections. The Brandemark technique is not prosthetically driven. If that is true, then let's revisit what prosthetically driven is. A non-resorbed edentulous jaw, the black dotted line, represents the crest of the jaw. The implants are placed on the crest. And if you have a screw-retained prosthesis, the screw's exit hole is through the cingulum of anterior teeth and the central fossa of posterior teeth. I think we all agree that the black dotted line and the red dotted line are superimposed in a non-resorbed ridge, an FP1 type of case. Well, if you have a resorbed case, the black dotted line shrinks inward, but the red dotted line does not move. So all of a sudden, the implant screw access hole is not in the central fossa. Then you take the resorption that happens further, and you see that the implants are placed on the crest of the bone, but there is a significant anterior, posterior, and horizontal cantilevers. This is not because the implant is palatally placed. This is because the patient's bone is palatal to the non-resorbed alveolar bone. This is a critical slide to understand so that you can demystify some of the information, such as this is not accepted by patients. So we entertain the idea this is not accepted by patients by having 2 publications on the quality of life. And every single patient in these 2 publications, which was over hundreds of patients who had had this type of treatment, said that if they knew what the outcome was, they would have done the surgery much earlier. So, what is the biomechanics on doing this type of a procedure? Again, unfortunately, a lot of misunderstanding of the literature, and these kind of references are continuously duplicated in current literatures. So let's take a look at them individually. Kato and Yojigawa said the zygoma bone is responsible for stabilizing the occlusal forces, and the reason is because the masseter muscle makes that bone very dense. We looked at that and we said the masseter muscle originates off of the zygomatic arch and not the zygoma body. And when you look at it in the cadaver, where the apices of the 2 implants are, is nowhere. That's not where the masseter muscle is. So unfortunately, well, there are muscles that originate from the body, but they're muscles of facial expression, zygomaticus major and minor, and they don't contribute to anything about the bone. So these 2 references are not quite accurate. Then we see this one that talks about comparing a Zaga 0 to a Zaga 2. So it's a comparison of 2 different techniques, supposedly the Brannemark technique with the extra sinus, with 2 different anatomies. It's like comparing apples to an orange and trying to come up with a conclusion that applies to both. So let's take a look at this again. Starting point is the same in both, and the ending point is the same in both. The trajectory of the implant is exactly the same in both. So they're the same technique. The only difference is that the patient is different. I did not draw those green lines. Those green lines are actually from the article itself. So again, there is one technique, and there is incorrect to say that one is extrasinus and one is intrasinus. Friedman did a study in 2013 and 15 where he made a model with quad cortical stabilization. He made a second model with only bicortical stabilization in the zygoma, no maxillary support. Under occlusal loads, he saw a tremendous increase in stress in the zygoma bone and the zygoma implant where there is no alveolar support. In lateral exertions, he saw the same thing. So having the bone available at the implant platform is critical. If we look at the literature, when an implant osseointegrates, regardless of whether it's 6 millimeters long or 10 millimeters long or 50 millimeters long, under occlusal loads, it's the first 3 to 5 millimeters of the implant that's loaded. The rest of it is just decoration. So why would that not apply to the zygoma implant? And it does, because when we see fractures, we see it in the first 5 to 6 millimeters where all the load is. So we need support in that area. So when you look at the literature and interpret it, the Michael Friedman analysis is the one that is accurate, and having crestal support at the implant platform is critical. Now, what did we do? We revisited this biomechanical study last year, and we took the Skalak model, the Jameson model, and we made our own model. We mimicked what the bone would look like at the alveolus on a resorbed case, the triangle. We mimicked what the bone would look like in the zygoma, the square. And then we placed the zygoma implant and did our measurements. So just to make sure we are all clear, we have a quad-cortically stabilized model, and we have a bicortically stabilized model with no support at the maxillary alveolar bone. We took this model from one of my patients, that on the patient's right side, there was quad bone, so we had quad cortical stabilization. On the patient's left side, it was a Zaga 4, so we only had zygoma stabilization. We studied the quad cortical stabilizations with a cross-arch splinted model, and also we studied the quad cortical stabilization with locators, which I don't recommend, but we did because I do see people doing it. And we did the same with only bicortical stabilization. We measured the vertical displacement of the implant when there was alveolar support and when there was no alveolar support. We measured the stress in the zygoma implant during function. We measured the stress in the maxillary bone during function, and we measured the stress in the zygoma bone during function. The results that we had was the amount of displacement of the zygoma implant if there was maxillary bone was about 11 microns. But if you remove the maxillary bone, it was 300 microns. That's 30 times more flexion in the implant. Well, who cares? Those numbers are close to titanium fatigue. If that happens a lot, just like a paper clip, when you bend it enough, it will actually break. So that is why these numbers are significant. We measured the stress in the zygoma implant at the platform, at the mid portion of the implant, and at the apex of the implant, both in the splinted model and the unsplinted model. And what we saw in the splinted model was if there was no alveolar bone, the mid-shaft had stresses from 94, it went up to 390. From 40 at the apex of the implant to 857. This is a 20-fold increase in the stress within the zygoma implant if you don't have alveolar bone. On the unsplinted models, we saw the same thing. The midshaft went from 122 to 514, and the apical stress went from 58 to 1200. So once again, a 20-fold increase in stress within the zygoma bone. Now, does it matter? Well, it could, and if it does, then we have to rethink the way we're doing our cases. So how about the stress in the maxillary bone itself and the zygoma bone? And what we saw, that if you have no bone at the maxilla, the stress in the zygoma bone was tremendous. But if you had bone in the maxilla, you can see how the bar graph drops almost to nothing. We saw that if you had, in the splinted model, no maxillary support, the same high levels of stress in the zygoma bone, and if you had maxillary support in the splinted model, those forces all dropped. So in the quad-cortically stabilized splinted model, the forces were all in the maxillary alveolar bone. So the maxillary alveolus is the primary support in supporting this implant. So if you have an option of having this type of an outcome or this type of an outcome, this is the one I am a lot more comfortable going home with. Now, an Indian group published a similar article last year. They looked at the same Yoshikawa, Kato, and Cavallero hypothesis that the zygoma bone must be the primary support of the occlusal forces. After they did their finite element, their conclusion was that the hypothesis was rejected, and it's actually the maxillary bone that's the primary support. We were excited to have this because at the same time, we had the ITI consensus on the zygoma implant that basically discussed the same thing, and my colleague, James Chow, will be talking about that in a little bit more. So once again, because this is absolutely critical, that is a Zaga 0, that is a Zaga 1, that is a Zaga 2, and that is a Zaga 3, and this is a Zaga 4. And if you superimpose it, it's exactly in the same place. So there's one surgical approach, and what ends up happening has to do with what the patient's anatomy is, and it has nothing to do with the type of procedure or technique that's different than the Brandemarks. And removing the alveolar bone is probably not a good idea. And I'm using that word because I'm trying to be polite, as my friend Joe Kahn is watching me closely. So the biomechanical literature is out there. If you can preserve the maxillary alveolus, if you can engage the maxillary alveolus with your implant, if you can quad-cortically stabilize the zygoma implant and cross-splint it, you have a very good outcome. The treatment protocols have all been presented in multiple articles, and basically there's one technique, and the only difference is the patient's anatomy. Thank you very much for your kind attention.